I think there's been an emergence of a refocus on this group. I mean, we've known for a long time that there are a lot of women who have ER-positive disease. Once HER2 was identified, we realised that many of them had HER2-negative disease, and we treated them fairly successfully with hormone agents for a long time. In the background, a lot of research was done, but they kind of dipped below the limelight. More recently, they're coming back for two reasons. Firstly, a recognition that sadly more women die of that particular kind of breast cancer than any other. But secondly, and this is important for those women, signals from years of laboratory research are now producing drugs that seem to have quite interesting therapeutic activity in addition to a background of hormone therapy. I think the most important thing is that the signal from the significant improvement of progression-free survival tells us, by adding an mTOR inhibitor, in this case it's everolimus, gives you a better breast cancer treatment. But when you follow that through to the overall survival data, we lose statistical significance. What we don't do is lose the amount of time gained in progression-free survival. So the median improvement in progression-free survival is 4 and a bit months. The median improvement in overall survival is still 4 and a bit months. However, for some of the women, they had 2 years or more after they progressed on the trial whilst they were still alive and being treated with breast cancer. So the signal of improvement is simply carried through, but the power for that same difference to be statistically significant is lost. It doesn't change my conclusion towards this drug. This drug improves the background of endocrine therapy with exemestane, and there's no negative consequences for having had everolimus earlier in terms of loss of efficacy to subsequent treatments. The community will say, well, there's no statistical difference in overall survival, which is true, but equally we don't lose the gain in PFS that you see earlier on. So I think a lot of us are not surprised because these women have many therapeutic options and they're kept alive by other treatments for, 2 or more years, which is good for them. I think this is a very exciting area. We have, for many years, contributed to the improvement in outcomes in breast cancer by throwing more and more treatments at patients. We're beginning to realise that not everybody needs them because not everybody has a high risk of recurrence. That's been known for a while. But increasingly, some of the drugs actually don't necessarily work against the cancer type. And I think there's a lot of exciting work about how you identify women who either don't need a treatment because their risk of recurrence is too low, or because although they may have a risk of recurrence that warrants treatment, there are particular treatments which have no effect on that cancer. I think it's a very exciting area because the aspiration, and the data suggests we will get to this area, we can better target treatments and treatment combinations to particular cancers rather than dishing everything out to everybody. This is another important area of development, and Mitch Dowsett is one of a number of groups who are asking the question not what predicts for your risk of recurrence, but if you've got through to 5 years on conventional therapy without a recurrence, actually, who are the ones who may benefit from further intervention? And that's, again, further personalisation of planning the therapies and the length of therapies according to the type of cancer you have. And I think all of this is taking us to a better place for tailoring a treatment for what that particular cancer needs, as opposed to everybody getting the same. These are interesting data because for a long time radiotherapy was, and it still sometimes is seen as a sort of thing that's done over there in the dark cupboards. And what's become very clear over the last 5 to 10 years is that whilst radiotherapy has been known for a long time to reduce the risk of local recurrence, there was a thinking, well, okay, that's nice for a woman, she doesn't have a local recurrence, but it is not going to change her survival. We now have had a series of studies, and the most recent data are important, to add to that, which is actually, if you prevent local recurrences with good radiotherapy, you prevent some women dying of breast cancer, and that's a huge gain for them. What the new data are that in women with what you might call medium risk breast cancer, 1 to 3 nodes, also get the survival advantage. We previously knew that higher risk women got it. We've now got the same information for the medium risk, which is a relatively common group of patients. I will be presenting some interim data, so caution, it's interim data, in a study where we treated patients who had just relapsed, just developed advanced disease, where conventionally we tend to throw a lot of standard therapies before we test new ones. We ran a trial in which we gave them a single novel agent. They got no conventional therapy. We watched them very carefully in terms of whether they were progressing, and part of the success story of the study is to demonstrate that you can do this. But what we saw was that inhibiting a heat shock protein 90, which can deal with a number of important cancer proteins, can actually cause shrinkage of breast cancers. We don't think this agent necessarily will be used as a single agent, but it gives a real excitement that, in a sense, a broader but thoughtful way of tackling molecular aberrations may actually be another way of targeting breast cancer. One of the key take-home messages is that we are finally beginning to see some real, genuine results of many years of hard laboratory and translational research. So, genomic predictors of who does and doesn't need treatments. Using molecular insights to overcome endocrine resistance in the Bolero-2 trial. Using molecular insights into the protein interactions to come up with heat shock protein 90 inhibitors. Taking the science really into the clinic. We've heard it before, but we're beginning to see more and more evidence that this is allowing us to tailor treatments to the patients. At the same time, and the radiotherapy data come into this category, we're seeing robust evidence that older conventional treatments are actually perhaps better than we thought they were. And that's great news for patients all round.